Hi guys, Dr. Dillard here. Kind of an important lecture here. Berry aneurysms. This is the most common cause of a subarachnoid hemorrhage. And then vertebral artery dissections, another kind of the chiropractor's nemesis right here, even though it's incredibly rare. These type of motions of the cervical spine, which include lateral flexion, rotation, and extension, can increase the chance for creating a dissection or knocking loose a piece of plaque. So let's get into it. Oh, it's spring 2021. It's week 5. It's Tuesday. Here we go. So we should do a little anatomy review here with regard to the Circle of Willis. So this is the Circle of Willis, but let's look at a cartoon to make more sense to us. It's also called the cerebral arterial circle or circulus arteriosus, some of the AKAs. Now there's an easier picture to see. So this is kind of a superior to inferior look at the base of the skull here. And yep, there it is. Right? It's right. The pituitary would be, let's see, did I turn on my drawing tools? Yes, I did. Pituitary would sit right here. Right, so this is some familiar anatomy. There's the clivus right there. There's the sphenoid, the body of the sphenoid, specifically the clivus portion. And yeah, so it's kind of surrounding there. The epichiasma would be right about in here as well, where the cross is, where the crossing of the tracks are. So yeah, it's formed by the union of two very important systems. Here's the carotid artery, or here's the vertebral arteries. Part 4, basilar artery, and then this, I'll do it in, let's see, green. And this is the Circle of Willis. We'll go through all these pieces here in a little bit. Right, so the vertebral arteries are really, they form the basilar artery, but they flow or give flow to the Circle of Willis. And then here's the very end of the internal carotid artery right here, which we've studied extensively in Gross 1 and Gross 2. We've studied this artery. That's where it ends. It dead ends into this Circle of Willis. So therefore, the two systems are the vertebral basilar system and the internal carotid artery system. It's specifically located in the middle cranial fossa. It's within the subarachnoid space and basically surrounds the sella turcica, the optic chiasma, and the clivus, sphenoid portion of the clivus, as we said. Here's another picture of the anatomy. I think we just went through all this. But there you go. Remember, this is like 3 steps here. This is the top step coming out of the plane of the page. This is the middle step, and this step is into the plane of the page. So these are the superior, middle, and posterior, anterior, middle, and posterior cranial fossa right here. And it's this middle cranial fossa where this thing lives. There's another nice view of it. Okay, let's look at the members. So you can read the members, but I'd just rather go over them. Let's go over them. So here's the basilar artery right here. Basilar artery dead ends into these arteries here, which is it splits into a right and left posterior cerebral artery, and then those go do their job. But the first big branch off the posterior cerebral artery is this clinically important one, and this is the posterior communicating artery. And this drawing is it's a perfect cartoon. In reality, one of these sides is going to be bigger. There's always a dominant system, a right system, or a left system. So one's going to be dominant over the other. This posterior communicating, it dumps in to the very terminal part of the internal carotid artery. So internal carotid artery is coming, if we can draw the rest of it, it would be right here. But this is where it dead ends. It basically splits into this kind of confluence right here, or where it gives rise to this blue piece right here, which is the anterior cerebral artery, and then it splits into a middle cerebral artery. So the end of the internal carotid artery splits into the anterior cerebral artery and the middle cerebral artery right here. Right? And then what happens with the anterior cerebral artery? It keeps going up here, heads up to the forebrain here, but it gives off a communicating piece right here. All right? And that is called the anterior communicating branch. So we have a posterior communicating branch in pink, anterior communicating branch. And yep, that is the Circle of Willis. That's super high yield. But we should note a couple things. Notice how the end of the internal carotid artery here, it's very close to the optic chiasma. What happens if you get a big aneurysm right here? Well, you can interfere with vision because of this. Same thing here. Look at how close the oculomotor nerve is to the posterior communicating artery. If you get an aneurysm coming off the posterior communicating, it can push in and mess up the oculomotor nerve here. So you can get a palsy, oculomotor nerve deficit, because of aneurysms here. That's where we're going. We're going to get into that even more. Just another picture. All right, now let's get into berry aneurysms that our anatomy muscles are built back up. It is the most common type of cerebral aneurysm, period. Of all cerebral aneurysms that occurs, and that could be in any cerebral, anterior, middle, posterior, any of the smaller vessels, this 90% of aneurysms are going to occur in the Circle of Willis. They are saccular aneurysms. Remember we said what that is already? Remember, here's a blood vessel, here's an artery. Saccular aneurysm is where a focal outpouching occurs in the blood vessel. Right? So that's a saccular aneurysm, and these things are breeding grounds for thrombus formation, right? Because the blood doesn't go in here very good, so you can get thrombus formation, can break loose and cause there's an embolism, arterial embolism, and that's not trouble, because these pipes are going to get smaller and smaller and smaller until they get down to a capillary, but this is going to get stuck somewhere and cause brain death. So they're almost always a saccular type, and it is the most frequent. If they rupture, it causes, because it's underneath the dura, it's between dura and pia, that's a subarachnoid hemorrhage. This lives in the subarachnoid space, so therefore it's a subarachnoid hemorrhage. And yeah, it is the most frequent cause of clinically significant subarachnoid hemorrhage, which makes sense because it's the most common type of aneurysm. Right? I don't know where I said that. Somewhere. But yeah, it's the most common type of noodle aneurysm that you have. All right. Subarachnoid space. Remember the so here's the skull. Remember there's two duras too in the skull, but this is just a cartoon here. Here's the dura mater. There's the arachnoid mater stuck together. The arachnoid mater is not that big. It's really, really thin, right? And here's the brain itself, the substance of the brain, like the gray matter. And you have the pia mater on top of the brain. And there is a space here where cerebrospinal fluid percolates through. And that's your subarachnoid space. So if you get a bleed, you get an aneurysm here. Let's say you get a saccular aneurysm. Oops. And it pops and bleeds, you're going to fill this space up with blood. And remember, there's a lot of blood vessels here. There's another artery here. That's going to be important here in a second. I think did I draw it? Yeah, I kind of photoshopped it in. But yeah, so that's blood in the cerebrospinal, or in the subarachnoid space. Does not like it. We don't like blood, or the brain does not like blood in the cerebrospinal space. Or subarachnoid space. Even that's the same goes for the thecal sac and the spinal cord. All kinds of trouble called arachnoiditis can occur when you get blood in there. Just another picture. Remember also we have these venous sinuses here, which are also dural folds. So that's also dura mater, and that's kind of a drainage system of the skull, or these big sinuses. That's the superior sagittal sinus. But remember, the cerebrospinal fluid dumps through these arachnoid granulations into these superior sagittals, or into, there's more than superior. It dumps into these dural sinuses and it's drained out of the skull. Gets into the jugular vein, the external jugular vein, and takes it back to the circulation. So most of these, where do these things occur? They tend to occur where at the junctions between the members of the Circle of Willis. I'll show you a picture in a second. About 30 million Americans a year are diagnosed with this. It usually cause a horrible, horrible headache, worst headache of your life. 4% of the population is thought to be walking around right now with these, and most of them are completely asymptomatic and have no idea that they have them. They're typically congenital in origin, specifically the part where the aneurysm occurs when people die and they dissect them. They find no tunica media or no internal elastic laminae, so that makes the vessel wall weak and susceptible. Okay, and they can't handle the pressure well, so they bulge out. Other risk factors would be the same as the ones that we've talked about for other aneurysms. What are those? Let's see, did we not talk about those? We're coming to those. Well, it's just some fun facts we're getting into now. These are more common than the vertebral artery aneurysms or dissections we're going to talk about. These aneurysms, like the anterior circulation, which is basically the junction between the internal carotid artery, the anterior cerebral artery, or the anterior communicating artery. If you have one, you got about a 25% chance of having another. So it's not uncommon to have multiple aneurysms. Here's a classic picture showing, there's one right there. 40% of them occur right here between the anterior cerebral artery and the anterior communicating artery. Between the posterior communicating and the end of the internal carotid artery is another favorite place for them to occur. Kind of down here at the junction where the basilar artery ends and splits into the posterior cerebral arteries. And then 34% occur out here further. Won't worry about that. Chances of a hemorrhage. Well, I guess I didn't. I thought I had a slide. Let me go back because that's bugging me. So other risk factors are the same for other aneurysms. So hypertension. I know there's a slide in here somewhere, but let me say this because it's bugging me. So it's not just you're born with lack of a tunica media. If you have hypertension, if you have a vasculitis in the brain, that can do it as well. A AV malformation, which we'll talk about later, is another tangled knot. So that's kind of congenital as well, but AV malformations are the other risk factors. I'm sure we'll stumble on that slide eventually, but what increases the chance of having a hemorrhage, or what are the chances of even having a hemorrhage? About 1.3% of the small ones will rupture and bleed, cause a horrible headache, may even kill you per year. So if it's big, anything over 10 millimeters in size, 50% of those are going to rupture within 1 year. Those are really, really dangerous. It's like flipping a coin, your chances, and the much higher fatality rate in these bigger ones because the bleed will be bigger. What happens if it hemorrhages? Well, if it hemorrhages, let's draw. I feel like drawing today. This is just all the brain. Let's say this is all the brain tissue. And we have a blood vessel going here. And let's say, I don't know, let's Broca's speech area here. And we have a blood vessel going to that. I'll leave a little space right there. All right, and this of course would break down into little tiny microcirculation. And then the vein would take it away. So we're servicing this area, this vessel. But you get an aneurysm, that's not going to affect it much. But if the aneurysm pops and you start leaking blood out like crazy, then the pressure downstream, and the amount of blood flow in here is going to significantly drop, right? Why? Because you're losing blood right here. So this whole area of the brain is going to become ischemic and not happy. You're going to get signs of a TIA, and it all depends on what area of the brain is affected. And if something's not done, which it's probably not going to be, because you can't get the head open and get a surgeon in there that fast, you're going to have a death. So in our case here, you won't be able to speak. You broke off speech area. See how that works? And that's called a stroke. Anytime you have a pop, and it doesn't have to be a bleed. What if you get a big piece of embolism comes loose from anywhere, from the left atrium, a patient with AFib. A big piece of thrombus gets in here and it gets stuck, right? So everything downstream will become ischemic. This will be a much bigger stroke. So, all right, do you think you know that? The weird rule of 33%. This is a weird rule. So 33% of ruptures occur during some high Valsalva's type event. Something where you're really straining down, like squatting 600 pounds, like other sporting events. Defecating, you have constipation, you're pushing really hard. Or you have BPH and your prostate is so big you have to push really hard to make the urine come out. Or during sex, having an orgasm. Anytime you hold your brush and hold your breath, don't breathe, and then push down. They always teach you to breathe, right, when you're weightlifting, so you don't increase the intrathecal pressure. But yeah, so 33% of the ruptures do occur in a Valsalva's event. More weirdness with this 33. What happens if you get a bleed? 33% of people die. They get a massive subarachnoid hemorrhage and it kills them. End of story. 33% become unconscious, which carries a bad prognosis. They might perhaps wish that they had died because they wake up and they can't speak or they can't move half of their body, or they're really severely disabled because of that. The 33% that stay conscious do fairly well. So it's always good sign if they don't pass out. What are the symptoms? This is a high yield slide. What are the symptoms of a bleed? 10-10 headache. Horrible headache. Migraine headaches can match this, 10-10 as well. Nausea and vomiting. Migraine can mimic that. Seizure, most migraines don't mimic that. Blurred vision, double vision, photophobia. Migraines can mimic that as well. Neurological deficits, migraines don't typically do that or mimic that. And that, facial numbness, paralysis, kind of a drooping face, left side of the body doesn't work or is weak. Those are all signs. Why did I say it's not good to get blood in the subarachnoid space? Blood does an interesting thing. So free blood floating around in the subarachnoid space, it's going to contact the tunica adventitia of other blood vessels. There's a lot of other blood vessels in there. And for whatever reason, there's a reaction that occurs when blood hits the tunica adventitia. And we don't understand it completely, but the research shows that endothelin is released like crazy from the endothelial cells. So there's some communication or pathway we don't understand. Arachidonic acid is also released that might be involved in it. Bottom line is you get a vasospasm of that adjacent vessel, and there's nothing wrong with it. That's perfectly fine, but when blood hits the outside of it, there's not supposed to be blood touching that. It goes into a reflex vasoconstriction, and it shuts all the downstream flow off, and it makes the stroke much, much worse. Hydrocephalus is another common problem. So if you're bleeding in the subarachnoid space, not only are you going to have that reaction by the other blood vessels, but fibrosis starts to occur. It causes an inflammation, a fibroblast heavy inflammation, And the end result of that are big lumps of scar tissue, and that can restrict the flow through the subarachnoid space. And it can get so bad that it can start to act as a beaver dam, so cerebrospinal fluid can't flow through the subarachnoid space well, and that causes the pressure inside the head to build up, and it can stop the drainage. Depending on where this occurs, it can stop the drainage into the dural venous sinuses as well. So that pressure buildup can severely damage the brain and lead to death really easily. And surprisingly, about 25% of people who suffer subarachnoid hemorrhage end up having at least some degree of this beaver dam in the brain where the cerebrospinal fluid backs up, and that's called a hydrocephalus when that happens. The distal carotid artery aneurysms and visual field disturbances. Oh, I do like this. This is my chance to get into a little bit of neurology here. So an aneurysm in the distal part of the internal carotid artery, right? That's where it gives rise to the middle cerebral artery and the anterior cerebral artery. Anterior cerebral artery is part of the Circle of Willis. So if you get an aneurysm there, it has a chance of pushing right in, has a chance of pushing into the optic chiasma. And this causes specifically a lateral visual field disturbance. And it'll be ipsilateral. That means the visual disturbance is on the same side as the lesion. And that's where I can change my word. I can put contralateral. No, it has nothing to do with the other side. But you might think, oh, there's a lot of crossing going on over there. But no, this is an ipsilateral nasal field disturbance. And why? Because it's taken out the tracts that go to the lateral retina. So here's a picture, the end of the internal carotid artery. Right here, internal carotid artery is going to split into the anterior cerebral artery right here. And the middle cerebral artery would be right here. And we also have the posterior communicating artery. It's almost a confluence here, right? But if you get an aneurysm here, it can push into the optic chiasma, the lateral portion of the optic chiasma. And yeah, this supplies the lateral part of the retina with sensation. And so if you lose this tract, you're going to lose your lateral retina, and vision crosses in the eye. So you'll have a blind spot on the temporal side toward the nose of the right eye. Did I leave that picture? Yes, I did. So yeah, basically, see how the tracks go? So here's the lateral retina right here. Hope this is showing up. My pointer's been having some trouble. But you can see the track right here. I'll draw it here. Lateral retina, there's the wiring, and this wiring does not cross over, right? So if you crush this, there goes the lateral retina, and there goes your nasal, the ipsilateral nasal field vision is gone. See how that's called? And that, of course, has a name. That's called monocular nasal hemianopia. Monocular nasal hemianopia. Hemi means unilateral, anopia means can't see, and it's the nasal visual field. Got it? Make sure you know that. So, posterior communicating artery. Kind of showed you this already. If you get an aneurysm off that, it can compress the mighty oculomotor nerve, which is a very busy nerve, right? We studied that in second quarter. And yeah, so you can get a palsy. And little side note, what is a palsy even? A palsy is a term used for when a cranial nerve is damaged and not working. So this is typically a palsy of ocular motor. It doesn't tell us whether it's a complete palsy, because you can use the word paralysis, means complete loss of function of that nerve, versus a paresis, which is an incomplete loss of function. All right, so there's an example. And there's the posterior communicating artery is pushing right into the oculomotor nerve. Uh-oh, here comes a rabbit hole. This is a wicked rabbit hole, too. Hang in there, because I do love this stuff, right? I love my anatomy. Don't get to teach it anymore, but I can get you right here with it. So you need to know this. This is super high yield board stuff. You need to know these extraocular muscles of the eye and what their functions are, right? So here we're looking at the right eyeball. So we have the 4 rectus muscles. These are all the extraocular muscles: superior rectus, inferior rectus, lateral rectus, medial rectus. Now, the cranial nerve 3 supplies which one of these? Or I should say, it supplies, which one doesn't it supply? Does not supply lateral rectus, right? That's the abducens nerve. That's cranial nerve 6. But the superior, medial, and lateral rectus. So if you get an injury of cranial nerve 3, these guys may be out of action depending how bad the compression of the nerve is. If it's severe, they'll all be out of action. So that leads to the next question: what is the action of these 3 muscles? Well, here's a chart right here. And Gray's Anatomy doesn't make you know the actual primary, secondary, and tertiary action. I put it in here anyway. And maybe neuroscience teachers will make you know that, but from an anatomy point of view, you just have to know what the actions are. You don't need to know the orders of them. Medial rectus is easy. It rotates the eye inward, which is called adduction, adduction. And if we go look for medial rectus over here, medial rectus, its primary action is adduction. That's it. So that's an easy one. Superior and inferior rectus are a little bit more complicated. Superior rectus rotates the eyeball upwards, so that's called elevation. Inferior rotates it downwards, inferior rectus. And we can confirm that by going over here. That's called depression. Yep, that's there. The next one is a little weird. Anytime you hear superior, whether it be superior oblique or superior rectus, it also causes the eye to rotate inward, right? We can't test this muscle. You can't make your eye do this. But some people have something called nystagmus, where you get kind of an abnormal twitching of these muscles. And if it's of superior oblique or superior rectus, you may see the twitching. It might twitch with a rotation like that. Right, so that's called intorsion. Intorsion. So that's the secondary action of superior rectus. And inferior rectus is the opposite. It's extorsion. It turns the eyeball like this. Another way you could describe it, if you put a stick, like the North Pole flag, on the eyeball. Here's the nose right here. Right, so if you rotate this way, that's intorsion. And if the stick moves this way, it's intorsion. If the stick moves that way, it's extorsion. Some authors draw it down here because you're still moving the downward part, the inferior part of the eyeball, toward the nose. So that's the same. That's extorsion as well. That's extorsion. So make sure you know the differences there. Okay, so superior oblique does intorsion is the second. It's actually the primary. Oh, I'm sorry, we're on superior rectus. Intorsion is the secondary, and then abduction is the other one. The tested moves for superior rectus, it's up and in. That's just how I remember it. It's up and in, up and in. So it's elevation and adduction, adduction. Right? So inferior rectus is down and in, so it's depression. Extorsion, can't test it though, so that may or may not be on a test question. And the tertiary movement of inferior rectus is adduction, also adduction. See how that works? Might as well do lateral rectus. That's really easy. That just can only do one thing. Rotates the eyeball that way. So it abducts the eye. Right? But that's the wrong cranial nerve, so they'll be able to turn their eye out just fine, right? Because that's not affected. Who's the other muscle here that's won't be affected in an oculomotor nerve injury? Superior oblique, right? That's trochlear nerve. That's cranial nerve 4. So that won't be affected. What does superior oblique do? And superior and inferior oblique are weird. Actually, the primary action of superior oblique is intorsion. Intorsion. I don't know if they've taught you that or not, but that is it. You can't test it. So the first testable action is just exactly opposite of what superior. You would think it rotates the eye up. It doesn't. It rotates the eye down. So depression of the eye, and then it rotates the eye outward. So ABD, abduction. Right? So intorsion, depression, and abduction. Got it? I think we covered it all, and you just had your CCP, so that should be easy for you, right? All right. Yeah, no, we're not done. Oculomotor nerve has more functions. So there is a ring of muscle around the iris that cause the iris to constrict. And they're called, they got a bunch of AKAs. They're called constrictor pupillae muscle, or sphincter pupillae is what Gray's called it. So that's what I would, if I'm going to test you on that, I'd call it sphincter pupillae. But it's parasympathetic. But remember, oculomotor nerve has parasympathetic fibers coming from the ciliary ganglia. And so it does control that. So if you lose your oculomotor nerve, it's out of action, you won't be able to constrict your pupil. So how do you test that? Well, shine a light in there and see what happens. If it doesn't constrict, there's something messed up with the oculomotor nerve. And just for completeness, there are dilator muscles as well that dilate the pupil. Those are under the control of sympathetic fibers. These are the sphincter pupillae is a parasympathetic fiber. It's affected by the parasympathetic part of cranial nerve 3. This is sympathetic fibers, and that dilation is called mydriasis. Mydriasis. This constriction is called, what is it called? You tell me. Not mitosis, meiosis. Oh, here it is over here. Meiosis. It's constricting. It's confusing. That's why I call, in genetics, I don't call it meiosis. I call it meiosis. Remember, in genetics, it's spelled a little differently. It's M-E-I-O-S-I-S. So even though most people still pronounce it meiosis, it's too confusing. Learn it as meiosis. And then meiosis, M-I, stands for eye, like your eyeball. Meiosis, meiosis. Got it? All right. So what are the signs of ocular motor nerve palsy? There's a zillion stars on this one. Well, we just said the oculomotor nerve goes to the superior, inferior, medial rectus muscles, and we just talked about those actions, so they'll be out of action. Your eye won't be able to do those things. All right? And it goes to inferior oblique as well. The muscles that are not affected will be the ones that are supplied by superior oblique and the lateral rectus. So basically, what do? They abduct the eye. They turn the eye out. So that's really the easiest way to test for this. If they can still turn their eye or abduct their eye, but they can't do anything else, it's an oculomotor nerve problem. See how that works? All right. So again, sphincter pupillae muscle will be taken out. The ciliary muscle will be taken out as well. Remember that? I've got some slides on that, but that's the muscle that you need to contract so you can see things up close. You won't be able to see things up close with cranial nerve 3 out of action as well. Right? We said this already. So sphincter pupillae causes meiosis. Dilator pupillae causes mydriasis, or I call it mydrosis. But mydriasis is the best way to pronounce that if you haven't already learned that in your head. That's interesting. Remember the superior cervical sympathetic ganglia we saw in anatomy? That was in gross 1. That's where the cell bodies for the wires that go to the dilator pupillae muscles. So if you get a tumor down in the cervical spine affecting that superior cervical sympathetic ganglia, you won't be able to dilate your eye. Your eye will be in a state of meiosis. All right, what else? Sphincter pupillae deficits affect the pupillary light reflex. So now we're going to get into this. Should be easy for you, right? The pupillary light reflex. So know this slide. So if you're cranial nerve free, let's say the left cranial nerve is damaged, cranial nerve 3 is damaged. So you'll have no indirect light reflex on the left, or you could say on the ipsilateral side will be out. You will have an indirect light reflex on the contralateral side. So when you shine the light in the left eye, the right eye will constrict. The pupil will constrict because there's nothing wrong with the fibers coming back. I'll show you what that looks like here in a second. If you're testing, well, yeah, we'll leave it at that. So accommodation, there'll be no accommodation on the left eye. That everything will be out. So you won't be able to turn your eye inward. You won't be able to, there'll be no meiosis, there'll be no constriction of the pupil as your finger gets closer to the patient's eye, and the patient won't be able to read anything up close. So remember how the wiring works here? I'm sure you've had this in neuroscience, but here's the left eye. We're shining the light in the left eye, and we have the efferent limb or efferent pathways are going through the optic nerve. They come to the optic chiasma and they split into two. So we had one signal now split into two. Then they pass the lateral geniculate nucleus, close to it, but they don't go in there. They go to the pretectoral nucleus, and they cross again into Edinger-Westphalt's nuclei, where the signal is now becomes an efferent limb. Did I say this? This is the afferent limb. Sorry about that. So afferent is coming into the CNS. ENS is going, or efferent is going away from the CNS. So now we're coming back the efferent limbs. So the key point here is with the wiring, if you shine the light in the left eye, the signal splits, the wires split, go to the brain, and they come back on two pathways. So they go in on one pathway and they come back on two pathways. So the efferent limb is our oculomotor nerve. So if we have a lesion affecting the left efferent limb, nothing's going to work, right? So the tongue-tied today. Pupillary sphincter or sphincter pupillae muscle won't work because its wires cut here, right? The ciliary muscle won't work because its wires cut. All the extraocular muscles won't work because the nerve is cut right here, right? See how that works? But you still have a signal coming back the oculomotor nerve on the other side. So this efferent limb on the contralateral side, in our example, the right side, there's nothing wrong with it. So when you shine the light in here, you're going to get a reflex contraction of the pupil here because there's nothing wrong with the circuits. This eye will also work. All the motions of this eye will be normal. You can abduct it, you can adduct it, you can elevate it, you can depress it, but not this eye. See how that works? Now what if we shine a light over here? Okay, now we're going to shine a light in the right eye. Pretend this is gone. But the lesion is still over here. How will that work? Well, the signal will go in on the afferent limb, just like before. It's not drawn here, but we can draw it. Signal goes in. It splits, just as before. So it goes both to the right and left pretectile nuclei. And then it comes back the right and left as well. But this time, this ocular motor nerve is fine. So the direct light reflex will work fine. So your eye will, the pupil will constrict. So meiosis is fine here. All the extraocular muscles are working. They will be able to read up close. Accommodation is working. But the other eye, the contralateral eye, the left eye, will be all messed up because that's where the efferent limb is over here. See how that works? All right. Accommodation, you guys usually, even though you've had the test, you probably still don't understand this completely, some of you. There's 3 different responses that you look for in the accommodation reflex. And the reason that it's confusing is because one of the effects is called the accommodation reflex. So the accommodation reflex is just one of the 3 responses to the accommodation reflex. I know it's confusing. Let's go through it and I'll show you what I mean. The reflexes by the same, the afferent limb would be cranial nerve 2, right? And I forgot to tell you, I mean, this is the optic nerve, that's cranial nerve 2, right? That's the afferent limb, and the efferent limb is still cranial nerve 3, so it's the same setup here. The efferent limbs are the same. The procedure, so you're going to have the patient look off into the distance. You're going to take your finger and hold it away from them, right toward their midline, and you're going to say, okay, now focus on my finger strongly and follow my finger as you bring the finger closer and closer to their nose, and you observe what happens to their eyes and what should happen to their eyes. Well, number 1, because as the finger gets closer to their eyes, more light is being reflected off your finger into their eyes. So it's sort of like putting a light into both of their eyes at the same time. And therefore, both their pupils should constrict. So meiosis should occur, or pupillary constriction should occur. If, back in our example, the left oculomotor nerve is shot, the left eye will not constrict in a patient with a tumor in the left. Right? So what else? You look for their eyes to cross. You're looking for adduction of both eyes. Same type of deal. If they have a lesion on the left oculomotor nerve controls the medial rectus muscle, and so they won't be able, that eye won't be able to adduct, right? So the other eye will be fine, right? So I think this is everything I just said. So convergence, everything I just said there. Positive is the failure of the eye to conduct, and that tells you that there's a problem with the oculomotor nerve. And same with meiosis, both pupils should constrict. Positive finding is it doesn't constrict. And it doesn't constrict on the side of the lesion. Third response, this is that weird, confusing one. So you have to ask the patient, most people forget to even do this. That's why instead of a finger, you can actually draw a number on the patient's finger, a real small number, because they have to be able to focus to make this work, or you can have them use a pen with some letters on it. But when you get your finger right up to their nose, you ask them, can you focus on your finger? Can you tell me what letter I drew on your finger? Or can you read a couple words on that pen to prove that they're focusing? That's the accommodation that we're looking for. That's the accommodation part of this exam. And the ciliary muscle, for that to work, for them to try to focus, the ciliary muscle contracts, which allows the lens to snap back in its normal fat state. And a fat lens gives you the ability to focus up close. Right? So this reflex, ciliary muscle contraction, is confusingly called accommodation, and you could call it the accommodation reflex if you want. It's probably better to just call it accommodation phenomenon, because the accommodation reflex is all 3 of those procedures. Right? This is another weird area of anatomy. So there's the ciliary body. Remember, there's these little parachute cords, and there's the lens. The lens likes to be nice and thick and tight in its natural state. So the ciliary body, as the zonulos, or as these little parachute cords are pulled tight, the lens gets thin. Okay, and then when you contract the ciliary body in an attempt to read up close, so let me draw this. So if the ciliary body goes like that, the parachute cords will be loose. Those zonulos will be loose, and this lens will fatten right out to its normal state. And that's how you can tell if it's working, right? If you relax the ciliary body, it snaps back to its normal state, which is also kind of short and stocky, and it pulls these cords, and it's more powerful than the lens. It can pull the lens right out. All right, there's just a picture of everything I said. All right, summing it all up. So convergence. So the accommodation reflex is made of convergence, which means your medial rectus, superior and inferior recti have to be working. Meiosis, pupil constricts as the finger comes in, and accommodation phenomenon, or just accommodation, as the ciliary body contracts and allows the lens to flatten back out, or fatten up, thicken to its normal kind of close range viewing. All right, that's out of that rabbit hole. All right, there's an actual, we'll go back to Berry aneurysms. There's a fatal Berry aneurysm, fresh dissection, and they had a huge one. You can see all the blood all over it. It ruptured. Associations. Cigarette smoking. So what increases the chance for getting a Berry aneurysm? Cigarette smoking, hypertension, atherosclerosis of the cerebral arteries, cerebral AV malformation. This is that slide I thought would be up further. There's more associations. Younger people with the connective tissue, Marfan's, Louis Dietz, Ehlers-Danlos type 1, neurofibromatosis. Coarctation of the aorta, which we'll get to here, is another risk factor. All right, let's take a breath. It's vertebral artery dissection time. Here we go. So a little more anatomy. Remember, we went over this in spinal anatomy, but here's an A to P view of the cervical spine. Here's the vertebral artery. Remember, part 1 leaves the subclavian artery. Once it dives in C6, remember it doesn't go in C7. The vein does, but not the artery. This is part 2 when it goes straight, the straight piece up to C2. So this is all V2. Once it goes through C2, it becomes V3. So this is part V3 of the vertebral artery, goes between 2 and 1, and then it goes between 1 and into the thecal sac. This is all V3 of the vertebral artery. Once it penetrates the thecal sac, you're in V4. Vertebral arteries come together to form the basilar artery. Got it? Here's a little drawing. I finally fixed it. The author had messed this up. Remember that posterior atlanto-occipital membrane covers this. Remember, we talked about a groove for the vertebral artery here. Remember, sometimes this can turn to bone. What happens when that turns to bone? What's that called? Posterior ponticle. But this is all V3. Once it penetrates the dura mater of the thecal sac, it becomes part 4. Branches, this is from spinal anatomy. It's good. You got your boards coming up. We should remember these. There's 2 meningeal branches usually that supply the occiput and falx cerebelli. There is an anterior spinal artery that supplies the anterior portion of the spinal cord and the medulla. I should have added in there as well. And do we have a picture yet? There's also a posterior and inferior cerebellar artery, which supplies the posterior inferior cerebellum and the medulla as well. It has some basilar arteries that it communicates with the basilar arteries from branches. it usually has a large branch coming off it posteriorly as well, off the posterior inferior cerebellar artery. Let's just look at the picture, right? Pictures are best. Here's that same picture from first quarter. So here's a vertebral artery coming in. That would be the left vertebral artery right there. Right, let's look at the branches. So we got the meningeal branch right here. Supplies the occiput with most of its blood. Then the next big branch is this posterior inferior cerebellar artery, which gives life to this part, the posterior inferior portion of the cerebellum back here. Off of that comes another branch called the posterior spinal artery, and there's another one on the other side. In reality, that should be back over here, right? It's on the posterior side. We just drew it. The author drew it on the front so you could see it, otherwise it's hard to see. And then the last branch off is this little wishbone here, the anterior spinal arteries, which quickly anastomose together to form the anterior spinal artery, which supplies the part of the medulla and the spinal cord. All right, and then remember they come together to form the basilar artery. And then we have might as well finish this, an anterior inferior cerebellar artery, which supplies the anterior inferior part of the cerebellum. So that basically takes care of the whole inferior portion of the cerebellum, the anterior inferior cerebellar artery and the posterior inferior cerebellar artery. And then we have one big superior cerebellar artery, which supplies the whole top of the cerebellum. We have a bunch of pontine arteries, so the pons gets many separate blood supplies. So why am I showing you all this? And don't forget that the posterior cerebral arteries here, right? This is part of the, well, I have to draw it. Remember, the posterior cerebral arteries give off the posterior communicating branches, right? There's the Circle of Willis, right? And that dumps into the very final part of the internal carotid artery. And then we have the anterior cerebral arteries here. And then we have an anterior communicating here. So there's a Circle of Willis. So why am I bothering you to show that? Or why am I bothering you to make you learn this again? Well, what happens if we get a piece of plaque growing here? This vertebral artery, let's say here's a big piece of plaque in blue. And it's occluding the artery. It's causing a beaver dam. But you do an adjustment on somebody, or they put in can lights, or they put in the ceiling fans, and they're working with their head in kind of weird places, and this breaks loose. So that's an arterial embolism, and where's that going to go? It's going to follow the flow of blood, right? And who knows where it's going to go? Maybe it'll roll right into the posterior inferior cerebellar artery, and the patient, what will happen if it blocks right there? Well, the patient will lose the posterior inferior portion of the cerebellum, so they'll get a stroke. So they'll be uncoordinated, and all sorts of problems will happen. See what I mean? This thing can go anywhere. Maybe it doesn't go in any of these, and it goes straight up and up and up and up, and it gets into the Circle of Willis, and posterior communicating artery is affected. All right, so you lose a huge chunk of the brain with an aneurysm like this. And if it pops, right, now it's leaking. So now you got blood in the subarachnoid space, and it makes things worse. So that's why these highways, these arteries are so important to know these things. Okay, now we're ready. Our anatomy muscles are strong. So vertebral artery dissection, it's just a dissecting aneurysm like we've talked about before, right? That's all it is. It's just a smaller scale. I don't think I even have a picture of it, but let's draw it. I'll leave a little hole there. So there's the vertebral artery. Here's the tunica media. We'll say this is the tunica adventitia right here. So blood, if you get blood going in through the tunica intima, and it rips through the tunica media, but it gets stuck here, it's going to usually rip the tunica media in half and go downstream. right? And the danger is it can rip back in, and all this, and this will clot in here. But as the pressure builds, it can all be released back in. I didn't draw this quite far enough. Let me extend this up. Let's make this a little higher. Okay, and we've done this before, so you know exactly what I'm talking about if you've seen that lecture. But yeah, so all this these blood clots can dump into the main circulation. So now you have all these emboli flying up like bombs, and they can get stuck all over the place, and you can get infarcts of the brainstem, of the cerebellum, any part of the brain really if it gets into the Circle of Willis. So very, very dangerous. So yeah, it's a longitudinal tearing of the tunica media, which we just said. It can come on very fast. There's two ways it can start. I just showed you one way where the tunica intima ripped. Another way is, remember, the vasovassorum can rupture, the blood vessel within a blood vessel. So even these tiny little vertebral arteries, some of them have a blood supply. Some of them don't need it, but some of them do. And you can get an aneurysm of the vasovassorum, and yeah, we talked about those before. All right, so what's the sequelae? Well, if you don't get double barreling, I just talked about double barreling, how it releases all that thrombus formation into the flow of the blood of the vertebral artery. Very dangerous. If it doesn't, you can get the false lumen can balloon way out because of the blood pumping into the tunica media can push out and cause a stenosis of the vertebral artery. So everything we talked about before, so I'm not going to repeat too much of this. But yeah, that can cause a general ischemia to everything downstream from the place where it's affected. I mean, that's everything. That's your whole, your midbrain, your pons, your medulla, your cerebellum, and even the part of the cerebellum itself, or part of the cerebral hemisphere. So it can cause a massive stroke. That's what I'm getting at here. What are the risk factors? Hypoplastic vertebral arteries. Sometimes people have, here's two vertebral arteries. So this is an angiogram where you can see, CT angiogram, you can see the arteries light up with contrast. There's a nice thick one there. Here's a patient who had a stroke. But you can see the normal vertebral artery is very thin right here. See, it's not nearly as thick as, it's much thinner than this one here, which is normal. And you can see they got a dissection starting right here. See how the artery suddenly got thin? If you follow it up, you can see they got a complete blockage right there, probably from the false lumen created kind of a stenosis so bad, very little blood was flowing through. But then it kind of picked up a little bit here, so some blood must have got through. But yeah, that's the story with that. This person did unfortunately have a stroke following a chiropractic manipulation. I actually worked on this case. I was a member of this team. What else? More risk factors with genetics. So the connective tissue disorders, Ehlers-Danlos syndrome, neurofibromatosis 1, Louis-Dietz-Marfan's. The same suspects. Some more risk factors. History of migraine patients tend to have a greater chance for cervical dissections. Coronary artery anomalies increases the risk. People have been on oral contraceptives for a long period of time. Alpha-1 antitrypsin deficiency, hyperhomocystinemia, all risk factors. Not going to get into them though. There is an important concept called the precipitating event, which is typically not very traumatic. I mean, some patients can suffer a stroke and need to go into the ER or have that horrible, horrible headache, and they had a dissecting aneurysm start, and all they did was work overhead. They put maybe their overhead can lights, a couple light bulbs were out, and they just worked overhead to put those light bulbs in, or maybe they're painting their ceiling. Any type of movement where you extend, laterally flex, and rotate your head can be one of these precipitating events. These people would have had these strokes eventually anyway. This is kind of like the straw that broke the camel's back, is what the precipitating event was, and it doesn't have to be very traumatic. So here it is in writing. A precipitating event, anything that hyperextends lateral reflexes and rotates the cervical spine, especially in combination, increases the risk for dissection or breaking a piece of plaque loose. We used to do George's test back when I was in practice, and that's exactly what it did. It extended your neck back, laterally flexed your neck to the, we'll say, the right, and then rotated your neck to the right at the same time. And you would ask if the patient, if they got dizzy, and if they got dizzy, spinal manipulation was contraindicated on them. But nowadays, at least in California, that test was actually causing strokes in patients. And so now we're not even allowed to do the test, so it makes it even harder to figure out whether these patients are risk factors or not. And don't worry, you'll have a lab dedicated to this in, I think, 6th quarter. I used to teach that lab, so I know what's coming. You'll be required to inform a patient of the risk of stroke following cervical manipulation. You'll practice that. All right. Some more precipitating events. The Valsalva's events: constipation, pushing, BPH, Valsalva's, anything pushing and holding your breath, weightlifting, orgasm, anything that raises the intrathecal pressure is a risk. Yeah, grade 5 chiropractic manipulation. Dr. Sousa, I think, is going to really get into this. This is kind of his area, so I'm not going to hit it that hard. But yeah, chiropractic manipulation has long been known. There is a once in a blue moon, super rare occurrence. It can cause a stroke in somebody. We're not exactly sure what the prevalence of this is. Some say Park says it's about 1 in every 20,000 chiropractic manipulations, which is probably about right, I think. Might be even a little bit rare. Chen is just absolutely ridiculous. He says it's 1% of chiropractic manipulations, 1 in 100. There's crazy stuff. Used to went on a big rant about an article where medical doctors were saying that almost every chiropractor has caused a stroke once in his career. Just absolute ridiculous stuff. Some research shows it's 0.00005. That's too far. It's more common than that. That's like the odds of you getting hit by a meteor. But yeah, Smith put forth some evidence saying that there's about a 6-fold risk for stroke following a chiropractic manipulation. It's definitely out there, but it's really, really rare. Probably like less than winning the lottery twice. Well, I don't want to say it's that. It's more rare than winning the lottery, though, I think. Nevertheless, American Heart Association and the American Stroke Society in 2014, through Sacco et al.'s work, did make a scientific statement that grabbed headlines. And this is the reason that we have to warn patients before doing cervical manipulation, because of this paper and this statement that came out. And it said, quote, "Most population control studies have found an association between chiropractic manipulative therapy and vertebral artery dissection for young patients. So patients should be informed of the statistical association between cervical dissection and cervical manipulative therapy prior to undergoing manipulation of the cervical spine." So basically you have to warn them about this. And so what's a vertebral basilar insufficiency? If you do suffer a dissection of the vertebral artery, and you'll create a true and a false lumen, right? I guess I should put some pictures in here, but I'm assuming you just remember it from the dissection lecture. But the false lumen can fill with blood, and the false lumen could push into the true lumen to the point it decreases the flow of blood through the true lumen. So therefore you're getting a downstream ischemia. And that ain't good, right? The brain needs blood. So that downstream ischemia will cause TIA symptoms and maybe even a stroke. So when you get that downstream ischemia, it's called a vertebral basilar insufficiency. Right. What about vertebral artery hemorrhage? Yeah, if you do have a dissection, or if you just have an aneurysm, there's always a chance that one of those precipitating events can cause it to rupture, and you can get a bleed, and that will cause the same problem. As that picture I drew, if you have a bleed, you're leaking out blood out in the subarachnoid space, and the blood's not going to the target tissue, you're going to get ischemic tissue, and that's going to be TIA or stroke if it's bad enough. And subarachnoid hemorrhage, where we talked about how the blood causes a reflex spasm in neighboring vessels, which makes things even worse. About 20% of people with that occur. Subarachnoid hemorrhage, 50% mortality rate even with treatment. So it's a very serious when you bleed into the subarachnoid space. How do you make the diagnosis? Vertebral artery CT angiography is we saw a picture of one already. That's the gold standard. There's a 7 Tesla MRI angiography, which is thought to be the new gold standard, but there's so few machines around that the CT angiography is still the key. Cervical MRI all by itself is pretty good. You can use the axial T1 fat suppressed images that can show the hematoma and blood really nicely. So here's a T1 fat suppressed image. And you can see normal vertebral artery here, right? This is an axial view. There's the disc, there's the spinal cord, and there's the vertebral artery. If you look on this side, the vertebral artery is really, really tiny. And we have kind of stagnant blood in a false lumen that shows up as white. Moving blood is black on this image. So you can see the false lumen, which is probably all filled up with clots at this point. And if that double barrels, you're going to release all those clots into the vertebral artery, and it's going to, it's going to wreck the brain. There's another one. So this is a double. This is a double aneurysm. Talk about bad luck. There's the true lumen in black. Flowing blood is black. Stagnant blood is white. No good. What do you do for these? What's the treatment? Well, you don't do anything for them. You send them to the ER. They can try to use thrombolytic agents to block, like streptokinase, to hopefully block or to cut open if it's a whole bunch of if it's a blood clot that's occurred in the false lumen, they can use streptokinase to try to cut that down. If you have an embolism that's stuck in the vertebral artery, same thing. Streptokinase will try to dissolve the clot, and it also sticks it to the endothelium so it doesn't go downstream and cause trouble. You'll be put on heparin to thin the blood to discourage it from clotting. And if they can fix you, you'll be on anticoagulation therapy, which will also help prevent clotting and thrombus formation. Thrombolysis is really dicey in this area because you can't put an IVC filter in, and this is arterial blood. It's under much higher pressure, so they are monkeying around with thrombolysis and stent placements, but not good. Surgery is the last gasp effort, and very high complication rates. 70% death rates have been reported trying surgery, so it's these really, really bad to get these things. Okay, coarctation, and we'll call it a day. This is really easy. This isn't heavy stuff. We've talked about this in lab already, and I think, have we talked about it before? I don't know, but here's a coarctation. It's a congenital narrowing. Usually occurs at the very start of the descending aorta, right after ligamentum arteriosum, right after the aortic arch. And it's a beaver dam. There's no blood getting through here. And so, yeah, that's not good. It's the 4th most common cause of congenital heart defect out there. Favors males over females. The incidence is like Marfan syndrome, 0.01% of the population. There is a genetic tendency to these things, often seen in twins. If one twin has it, the other will have it. Or if a brother has it, a sister could have it. So there's definitely a genetic relation between it. Here's a 3D reconstruction showing the aortic arch. And you can see very little blood is getting through here. It's spraying through here, so it's caused a little bit of an aneurysm here from the high pressure. But all in all, after the spray settles down, the volume is decreased here. And what is this patient? Is this patient going to have hypertension, if anybody's still with me? Absolutely. They're going to have hypertension. You got a beaver dam right here. Where do you measure your blood pressure? Well, that's your brachial artery. So this is going to, here's your left subclavian right here. That's going to ultimately lead to your brachial artery. And the pressure is going to be much higher in all of these pipes. And the heart's going to be working very hard to try to push through this. So the heart's going to eventually fail. It's probably not going to do a very good job at getting the pressure high down here. The low pressure is going to do what to the R2A system? Yeah, see how you got to think with this? Yeah, low pressure in the kidneys, the R2A system is going to be turned on. All right. So how are the pulses? What if you take the ankle pressure? Take the dorsalis pedis pulse. Or you get the pressure down there. It's going to be low, right? And the pulses are going to be low, but the upper extremity pulses and the carotid pulse are going to be strong. Superficial temporal pulse is going to be strong, but all the pulses in the lower extremities will be weak. That's a sign of it. If you have this condition, you have to watch out for baryaneurysm, because these patients may also have a baryaneurysm and other problems like a patent ductus arteriosus, patent foramen ovale, bicuspid aortic valve. Key diagnostic signs. What we said, lower limb pulses are greatly decreased. Upper limb pulses are exaggerated. And yeah, that's because of the beaver dam. I already explained it. Okay, so that's kind of a heavy lecture. See y'all later. Send me those email questions.